So like I was saying, before we started class tonight, we got good news and bad news about your instructor. The good news is, you all know he had the connection issues on Tuesday night. He was having that hard, y'all couldn't hear him. So we did the recording and we uploaded it. So the good news is we figured out what the problem was. His fiber line on the offshore rig has been nicked or cut or something. I don't know what happened, but they are having some issues. The bad news is that they're still trying to fix it. So he's out of commission. I'm going to be teaching for y'all tonight. I'll be your substitute teacher. And we're going to be going over BLS resuscitation. Now, anytime we refer to CPR in EMS, as far as EMTs are concerned, we call it BLS. All right, basic life support. If you think about it, when you got certified in CPR at the healthcare provider, they didn't call it CPR healthcare provider, they called it BLS. So that's the term that we're going to be using here. And if you've got, is anybody not currently certified in CPR? Before we go into this, everybody should. Okay, all right, then that's fine. Not infrared, that's fine. You know, most EMT schools require you to have it before you start, and you have to be current through the class. Because we renew you in the course, that's just something extra that we do that a lot of schools don't. I don't really require it. So you guys tonight will be your refresher, and you're gonna get, once you do the boot camp where we do the hands-on, um, that's gonna be what completes your refresher, and you're all gonna get a new BLS card. So you're gonna get that. Don't sweat it. But the reason I ask is because if I have a class and everybody's certified, then a lot of this stuff is just stupid crap you already know, like 30 to 2 and things like that. But being that we do have some people in the class that aren't currently certified, this will be your refresher. So we're going to hit all the numbers. For those of you that did just recertify somewhere else, I apologize. Just bear with us. But I'm going to make it worth your while as well. We're not just going to talk about the numbers. I'm not going to butcher you with the 3-hour DVD of CPR and the guy that's wearing the denim shirt from the 80s and all that stuff. We will review the numbers, but I'm also going to get into the physiology of BLS and why we do what we do, because this right here is one of the most underrated, often abused, often screwed up things that EMTs and even paramedics will do, because we get it in our heads that we do CPR all the time, and no, we don't. No, you're fine. Tonight is your review, your renewal, so you're not going to do anything with that. We just underestimate BLS. We're like, oh, just pump on the chest and don't, the whole 30 to 2, don't worry about it. And we're not going to do that, and we're just going to concurrently do breathing and compressions. And how many people have seen that in the field, where they tell you don't stop at 30, just keep going? And the guy with the BVM, they just throw that to the new guy who's not really done anything before and say, here, bag this patient. And that's the code. That's how it runs, because the paramedic doesn't want to deal with BLS. They want to deal with getting their ACLS drugs together and push through, which they need to. But they don't. They just, CPR just kind of, the quality of it goes to hell, and it shouldn't. And we're going to talk about that tonight as to why that is the way. Why do we do the compressions that we do the way that we do them? Where do those numbers come from? Blah 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 blah. I find it interesting. I love knowing why things are the way they are. And it really helps to understand why I'm doing what I'm doing, as opposed to just being told to shut up and color, which is what CPR is otherwise, if you don't know what the reasons are behind those steps. And hopefully by the end of this class, you'll know why I get on my soapbox about bad CPR, where people are like, well, it doesn't matter. We're just going to push on the chest, and this whole 30 to 2 crap doesn't matter. It doesn't do anything and everything. And yes, it does. It absolutely does. So anyway, let's get going. We're going to skip your introduction. Well, not the introduction, but the competencies and everything. Your competencies tonight are basically AHA, American Heart Association, BLS for the healthcare provider. There is extra stuff in here, so bear with me. First time we started doing CPR was in the 60s, and it has changed every couple years since then. Now, the standards actually come from the ILCOR. It says it at the bottom of this slide. That is not, the AHA doesn't make their curriculum. Anybody ever notice if you've taken AHA curriculum and say Red Cross CPR, it's the same? They don't teach anything different. So why does it matter why a company might want to get an AHA card versus a Red Cross card? Usually it winds up just being because somebody at a desk somewhere said, well, we're only going to accept AHA because they're the credible ones and everything, but it's not like it's an AHA curriculum. We do AHA, that's what you're going to be recertified as, and we do that not because we think it's the best, but because that's what most hospitals, most ambulances want you to have, and why give you something that may not be accepted. But anyway, all of these companies that do CPR, be it the Red Cross, um, American Heart, whatever, they build their curriculum off of the research that's done by the IL Corps, and they release it every few years, and it updates. And in fact, it just updated again. We've been teaching off the 2015 curriculum for the last few years, and as of October of last year, October 2020, the 2020 curriculum finally came out. And big shocker, there's really not a whole lot of difference between the two. The coolest thing is we got new DVDs. So 2025, we're going to get new curriculum again, and we'll see if anything has changed. New technology comes out. Usually that's the big driver of what the changes are, is because AEDs are different now. So we start teaching to the current AEDs. You also have LVADs and stuff. We're going to talk about all that stuff tonight. All right, so BLS is non-invasive. That is kind of your wheelhouse as EMTs. It's basic life support. You have basic and advanced. Anything that is invasive to the body, be it through an advanced airway, an IV, medications that go in straight to the veins or anything like that, that's ALS. You guys operate more with the CPR aspect of this. So you can do OPAs and NPAs for the airway. You can do King airways and combi tubes if that's allowed in your systems. These are the things that you do because they don't go past the cords, so they're non-invasive. As far as CPR goes, it is obviously non-invasive to do a chest compression, but that being said, it's probably the most important thing. Because if you're not circulating the blood, then it doesn't matter how much air you give them. It doesn't matter what medications the paramedic gives them. It's just going to hang out in their vein, and it's not going to do anything. So as basic as it seems, the compressor is the most important role, and doing it with a good quality is one of the most important things that you can get in BLS. What we're going to cover tonight, airway obstructions, we're going to cover respiratory arrest and cardiac arrest. There's obviously a major difference between the two. Arrest just means to stop. So if you're respiratory arrest, that means your respirations are stopped. If you're in cardiac arrest, your cardiac system is stopped. And then if you're in both, that's where you're going to do CPR. If it's just one or the other, you're not doing CPR. You're doing either rescue breathing, or you may be doing compressions, but they're still breathing, so you're not worried about the BVM. Usually that's not the case, but theoretically that's the difference between the two. We do still focus on the ABCs. All of your assessments that we've talked about to this point, be it a medical assessment or a trauma assessment, it's always been your scene size up, those 6 things that you count off, right? So BSI, scene safety, number of patients, need for additional resources, your mechanism of injury or your nature of illness, and considering C-spine. Remember those 6 things. Get it to where you can rattle them off. That part doesn't change. But let's say that you show up to a patient, and whoever wants to answer this can unmute. Let's say that you show up to a patient, you've done your scene size up, and you enter the room, and this guy is laying on the floor, and he looks dead to you from the other side of the room. Are you going to, I'm going to give you 2 options. Are you going to, at the beginning of your primary, open his airway or check a pulse?
Check a pulse.
Check a pulse, exactly. So this is the first fork in the road, is the best way that I can put it to people. When you are trying to learn your assessment and everything, we're going to a lot of background noise on you, man. All right, yeah. So a lot of people, when they're going through their assessment, they they get so hung up on the fact that it's ABC in their primary, and you kind of forget the fact that if you don't have a pulse, it really doesn't matter what you're doing with the breathing. You're right, your ABC and your assessment, but if you think about what you were taught in CPR, we do compressions first, so it's CAB. Um, and in that case, how do you know which one you want to do first? Well, if you look at your assessment, you have within the primary, you have a level of consciousness check. That is something that you typically will do either in your head or very quickly. Like if you see somebody that's on the ground, hey, are you okay? You can do a sternum rub, you can pinch their shoulders, that kind of thing. But as soon as you've determined that they are completely unresponsive, you are at a fork in the road. Do you go ABC or CAB? And the only way to know that is by checking a pulse. So that's your next step. How long do we check a pulse? How long do we get to check a pulse before we make a decision whether or not we're going to do compressions or not? Good, 10 seconds. Now that's a 10-second max. All right. And there's going to be, through this course, there's going to be a few times where I ask you guys how long you're going to do something. If I'm asking about it in terms of time, when in doubt, just say 10 seconds, because that's pretty much a magic number. It's 10 seconds for a pulse check.
36.
Alex, I'm going to mute you again, buddy. Do me a favor, Alex, if you need to say something, if you can, type it. Your background noise, I don't know if you're riding down the street or something, but it's really loud. But anyway, on my little tangent here, anytime I ask you a question about time, consider 10 seconds to be your answer. It's 10 seconds for a pulse check, 10 seconds to give a breath. Your two breaths rather for BLS. If you ever have to suction a patient, it's 10 seconds. All right. Now, granted, yes, real world, if you've got to suction a patient, we suction until the airway is clear, because what good is 10 seconds if it doesn't do the job? On the test, however, it's 10 seconds. All right. So make sure you can differentiate that. That's one of those things where you show up to your job and they're like, forget what they taught you in school, because the whole 10-second thing is, but it really is. It's bogus. But the point being is that if you suction for too long, you can drive down their vitals. So they give it that 10-second rule. All right, so we check a pulse, we check it for 10 seconds, and we're either going to get one or we're not. If you don't get a pulse, then whatever your assessment, medical or trauma, it's put on pause at that point, and you're going to move into your BLS resuscitation checklist, which is just CPR. So instead of doing ABC, now you know that you need to do CAB. So you're going to immediately start with compressions, and we're going to go through regular CPR. If they do have a pulse, then they don't need compressions, unless they're a kid, and we'll get to that. But if they do have a pulse and they're an adult, they don't need compressions. Their heart's beating. So we're going to provide what's not there. So at that point, go ahead and look at their airway and breathing and make sure that that's there. Because if you lose one, you're going to lose the other. They may have a pulse at the moment, but if they're not breathing, they're going to lose the pulse. So CPR is kind of a check it and provide it if it's not there. All right, we check a pulse. If they don't have it, we're going to give them one. That's their compressions. If they do, great, we move on. Check an airway. Open the airway, give them an airway. Check their breathing. If they're breathing, great. If it's good enough, if it's either insufficient to support life or it's just not there, then we're going to provide that with a BVM. Just a second. Okay, I guess everything's good. We have a new instructor teaching tonight, and I'm kind of working tech support for him as well as teaching for y'all. But anyway, so that's how you're going to get into your BLS assessment. So again, you do your scene size up, you get all 6 things. You show up to your patient. If he's laying on the ground and he ain't doing nothing, do a quick level of consciousness check. Hey, are you okay? If he's not answering you or not grunting or groaning or giving you any kind of a response, check a pulse. Just make sure you're not talking to a corpse. If he's got a pulse, then great, continue on your assessment. If he doesn't, then we're going to go into CPR, which begins with C. All right, time's critical. Time's really not on your side when it comes to CPR or cardiac arrest, rather. So 0 to 1 minute cardiac irritability. Um, 0 to 4 minutes, not really going to get too much brain damage. Once you start getting above that 5 minute mark, you start to deal with irreversible changes. So brain damage is possible. 6 to 10 minutes, brain damage is very likely. If it's more than 10 minutes, you're dealing with irreversible brain damage. And this is not necessarily time in cardiac arrest in general. This is time without adequate CPR. So if you show up at the 10 minute mark, or not, I'm sorry, not 10 minutes, the 2 minute mark, and you start compressions, you start CPR, and you're doing a good job of it, then you basically stop this clock. Even if you're doing CPR for 30 minutes all the way to the hospital, as long as they're good compressions. If your CPR suffers, then you're just wearing yourself out for no reason. So make sure that everything you do about BLS, that you give it a quality that is going to matter. If you're just beating away at the chest and not giving any air, or or you're giving air but it's going into the stomach, well, that's not doing you any good. That kind of thing. All right. So let's talk about CPR in general. This is cardiopulmonary resuscitation, cardio being the heart, pulmonary being the breathing. So if you're going to do full-blown CPR, that's because they neither have a pulse nor a respiratory rate. If they've got one or the other, then you're not technically doing CPR. I know this sounds elementary, but you're going to get questions on the registry that may trip you up, because they may be like, you have a patient that is not breathing, and your next step will be, and then you're going to get an answer that's like, start CPR beginning with chest compressions and give 2 breaths after a set of 30, which is a fantastic answer if they don't have a pulse. But the question didn't tell you they didn't have one. So one of your other answers may be check a pulse. And another answer may be open the airway, because they want to see if you know how the primary is going to shift at this point. Those are the kind of questions you may see. I don't want those to trip you up. Some of you guys may have attempted the registry before, so you know exactly what I'm talking about. And they don't give you any bold words, they don't give you any underlines, nothing to draw your attention. They just want to see if you catch it. And it's kind of an unfair thing, but it is what it is. I don't get to write the test, sadly. All right, so there's 3 steps. First of all, we need to restore circulation. That's the C. So you're going to do your chest compressions. After 30 compressions, you're going to open the airway, and then you're going to give 2 breaths. The giving of 2 breaths is done over 10 seconds, just like checking the pulse. And I will tell you, please, for the love of God, don't do like everybody does in our CPR classes and just go, and that's your 2 breaths. We don't breathe like that. CPR is supposed to mimic normal body function. So when you're compressing at that rate of 100 to 120 beats a minute, you're basically providing a pulse at a rate of 100 to 120 beats a minute. When you give your 2 breaths, they need to be like normal breaths. So you open the airway, you get the BVM in place, or your pocket mask, or whatever you're using, and you're going to give a breath that takes about a second to complete the breath, and then you're going to give them that good 3 to 4 seconds to exhale it. Then you're going to give them another breath that takes about a second to deliver, and you're going to give them 3 to 4 seconds to exhale that. Now you only have to give 2 breaths. So after that second breath, which is at the 5-second mark, then you can, if you're by yourself, you can drop the BVM, get back in place, and be ready to do compressions pretty much as soon as you can. You don't even have to wait for the 10 seconds. If you can give that second breath at the 5-second mark and be back on compressions by the 7-second mark, then that's even better. And again, like I said, there's a definite reason for that. And it gets into cardiology, which I will try not to geek out too much to, but I do want you guys to understand that. So we'll get to it in a few slides. Just a picture of 2 rescue or CPR. Compressions are by far the most important part of CPR. So if you can't give breaths, then don't give breaths. If you don't have any oxygen, well, tough. They don't get any oxygen. But you got 2 hands, so give them compressions. All right, so BLS versus ALS. You guys, like I said, you guys are the masters of BLS, or at least you will be. If not by the end of this course, which I hope you are, but as you go through your career. And you, like I said, don't take it for granted, but you'll be really good at BLS if you keep the quality up. ALS is advanced. That's going to be your paramedics. They typically do the cardiac monitoring where they put the 12 lead on, IV fluids and medication. So if you've ever heard of, epinephrine, used to be atropine that we gave in cardiac arrest. We don't do that anymore. We'll give lidocaine. We'll give amiodarone. Those are your ACLS drugs. So that's the paramedic stuff. That's ALS. All right. And then your advanced airway, what's the difference between a basic airway and an advanced airway? Type it, especially if you got a lot of background noise. There's a landmark difference that has to do with the body. I've said it a few times to see if anybody remembers. Advanced is intubation, right? So what are you going past? The cords, good. That is your dividing line between BLS and ALS. So if anybody in your system ever tosses you an airway and you know how to do it, as long as you're not having to visualize cords and push past them, you can do it, as long as your system allows it. Somebody throws you an ET tube, you can throw it back at them because there's no way to properly put that in without going past the cords. That's out of your scope. All right, so let's talk about the chain of survival. I'm not going to harp on this like the CPR DVDs do or like we do in our AHA classes, because you have a definite link in this chain, and the beginning chains really don't apply to you. They happen before you ever get the call. Early recognition of EMS or of CPR and needing EMS, so call 911. Like I said, compressions are the most important aspect of CPR, so they're going to start first. And then rapid defib. The reason that rapid defib is so important is because the defibrillator will shock two rhythms. There's two rhythms that I need you to know are shockable rhythms. If y'all want to write this down, you can. It's V tach and V fib. So ventricular tachycardia, which means that the ventricles are the ones driving the heart. They're the ones setting the pace, and they're going way too damn fast. All right, they're going fast to the point where they can't push blood because the time between beats doesn't allow blood to actually move back into the ventricles to be pushed out. That's VTAC. All right. VFib is the progression of that. So a lot of times, most heart patients are going to start off with electrical issues, and they may go into something like VTAC. All right, heart starts racing, and it's no longer listening to the SA node. If you remember back in the anatomy chapter, where the SA node is your primary pacemaker, and it's up in the atria. The ventricles aren't listening to it anymore, and they're just off to the races. All right, the heart's no longer getting blood because blood's not flowing. So it's not just the body that's deprived of oxygen; it's also the heart itself. The heart's going to start to wear out. Then it's going to go into VFib. VFib stands for ventricular fibrillation. That's where there's no more organized rhythm. So instead of just, flying off with a high pulse, now the heart's just kind of quivering, and there is no pulse, there is no steady beat to it. None of that stuff. It's just kind of shaking. The shocks that cause the heart to contract are coming from all sorts of different places, as different parts of the heart are trying to say, "Hey, I'll take over. I can do it better." And they can't, but the heart's just kind of shaking and shivering. When that happens, now there's just no more beat. So it really isn't about the fact that the heart can't fill the ventricles anymore. It's just, even if they've got blood in them, there's no real contraction to push them forward, both of which fail to provide blood to the body and to the heart itself through the coronary artery. So eventually the heart's just going to give out, like it can't do it anymore. There's no oxygen, the cells are dying. Those two rhythms are shockable. You can look at a defib. Anybody ever watch a movie? I know The Guardian did it, the Coast Guard movie way back, where the rescuer is trying to save the guy, and the guy's freaking out and like, "Oh my God," he's not listening to orders, he's not listening to the directions of the rescuer and whatever, and the rescuer just backhands him, smacks the crap out of him, and it stuns the guy for a second. He's like, "What'd you do that for?" And then now he's listening to the rescuer. That's what the AED does. All right. It basically just backhands the heart and says, "Stop and listen." Hopefully the SA node is still firing, and the heart's like, "Oh, there's the pulse," and it starts beating like it should. If you can get an AED on somebody fast enough, a lot of times those rhythms can be corrected with that. If you can't, or if you just sometimes those rhythms are refractory, which means they resist the AED. The AED doesn't do it. But a lot of times your cardiac issues will start there. So if you can get the defib on them fast enough and shock one of those rhythms, you may not ever have to actually do a chest compression, which would be fantastic. Because I don't know about y'all, but I ain't as young as I once was. My back starts to hurt pretty quick in CPR. All right, but if that's not good enough, if you are in fact having to do full-blown CPR, the AED is not helping, then the next link in the chain is to get them actual care. This is where you come in, right? Everything up to this point can be done by the Walmart employee or the grandchild or whatever. You are the responder in the fourth link. You're going to take over links number 1 and 2, or I'm sorry, number 2 and 3, and get a paramedic out there as quick as you can. Because a lot of times, if that's the case, CPR alone is only going to maintain what you've got and stop the situation from getting any worse, but it may not bring them back. The ACLS drugs, even though they're kind of a best guess, they're always coming and going in new protocols because we find out that some of them don't work. But some of them work really well, like epi. You can get a pulse from a rock if you give it enough epi, but it doesn't necessarily mean that it's going to be one that will sustain life. All right, so the AHA harps on all that. I just wanted you guys to know where you fall in the chain and why the chain is what it is. So early CPR, right? Get that blood flowing. Early AED, because you may be able to correct a rhythm before it goes into asystole, which is a flatline, and that is not a shockable rhythm. If they're already flatlined, a shock's not going to do anything. And there's a couple other rhythms we're going to talk about tonight where a shock won't do anything. But I want you to still be able to recognize those patterns because they can be tricky, like pulseless electrical activity. Paramedic shows up, hooks up a monitor, and you see a rhythm, and it looks beautiful. All right, it looks like they should be sitting up talking to you, but they're dead on the floor. So what's going on? They're called pulseless electrical activity because the electrical side of the heart is functioning, and it's functioning perfectly fine. But the hydraulic side of the heart's just it's not doing anything. So AED or even a pacemaker is not really going to fix that. It's going to wind up being that they need compressions until they can figure out why the heart's not responding to the electrical impulses. A lot of times it's something reversible that the hospital can fix, but unfortunately for you, that means you're doing compressions until you get them there. If any one of the links is missing or absent, the patient is more likely to die. Just kind of makes common sense, right? If you got a patient in cardiac arrest and you don't give CPR, they're probably not going to do too hot. And then I also want to mention something about this before we move on. So back to this slide right here. The patient's more likely to die. Let's talk about survival rates, because this is something that I hear from a lot of medics, especially long-standing ones that are risking burnout and stuff like that. You get the mindset that CPR is a waste because the survival rates are so low anyway, and if we're going to have to do CPR, then the patient's probably not going to live, and blah blah blah. And yeah, that's true, especially if you suck at CPR. The survival rates are pretty low, right? I want to say it's something like 8 to 10% survival rates, but I want to give a caveat to that. The way that statistic is made is that they're looking to see who survives 1 year past ROSC, which is ROSC stands for return of spontaneous circulation. In other words, you could go into cardiac arrest. You could get your pulse back. You can go back to normal life for 11 months and 30 days and I don't know, 1 minute shy of being a full year. And then you get hit by a car and you die. You don't count towards the survival rate for the CPR because you didn't make it a year. It sucks. That's the way they do it, and that's a flaw in the survival rate as far as statistics go. That being said, survival rates for CPR they're actually much better when you factor that in. When you take out people that died from another cause within a year, they're out, or the survival rate would go up. Because when they run those statistics, they don't bother asking what the cause of death was. If somebody is not still alive 1 year after CPR, That's as far as they go with it. They can't ask, they can't get, because of HIPAA violations and stuff, they can't get a lot of the information that determines whether or not they just went back into cardiac arrest, or if, a meteor fell on them or whatever it was. So don't let that mindset of, survival rates are really low. Like, yeah, they are, but that whole statistic is kind of bogus. Should be much higher. All right, so assessing the need for BLS, like I said, you guys as EMT students, you're going to be treating this just like you do any other assessment at this point. So survey the scene, BSI, scene safety. You're going to go through your scene size up, get to your patient, determine their level of consciousness. If they are responsive at all, they're probably not going to need CPR. All right, so if they're awake talking to you, dead guys don't talk. If they're responsive to verbal, responsive to pain, that means that their cells are still perfusing. There's still some kind of blood getting to the brain, so they must have a pulse. If they're completely unresponsive, those are the ones that you're looking at that you're probably going to wind up doing CPR on. And that begins with a level of consciousness check to, first of all, determine that they're unresponsive, and then go straight to a pulse check. And that determines how you're going to proceed through your assessment from there. Sorry, my nose is running. The basic principles of BLS are the same regardless of the age. We do change the way that we do CPR a little bit, depending if it's an adult, child, or infant. But for the most part, it's all the same guidelines. For purposes of this class and for medical in general, an infant is anything younger than a year. A child is 1 year to puberty, and an adult is puberty and above. So a 15-year-old kid that looks like a grown-up, treat him like a grown-up. A 12-year-old child that looks like a grown-up, if he's hit puberty, he's going to be a grown-up, right? We're not talking about this from a legal standpoint with permission to give care. We're talking about this from a physiologic standpoint. And although cardiac arrest in adults usually occurs before respiratory arrest, the reverse is true, especially in infants and kids. Usually, there's nothing wrong with the child's heart, and if there was, a lot of times the hospital will know about it, the family knows about it. Children's hearts they don't have like coronary artery disease or things like that. Usually it winds up being a respiratory issue that led to cardiac arrest. You get to be, older in life, that's different. Your heart's, whether it be something genetic, or it could be something along the lines that you just had a crap diet for 40 years and you've clogged your arteries or whatever. That's different. That's usually cardiac first and then respiratory. But kids are respiratory risks, so a lot of times they're going to be, the biggest concern is also going to be making sure that they don't continue to not breathe or whatever. And we'll talk about how the 15-2, where you cut your compressions in half for children if you've got multiple rescuers, that's why. All right, we don't want to change the order because we don't want to confuse people. But if you have multiple people, that 30-2 that we're going to talk about gets cut in half. That allows the child to get more breaths in a time span. So what if they are born with heart problems? If they are, it just depends on what the heart problem is. And like I said, a lot of times the family will know about it, unless it's I don't know, maybe there's some religious sects that don't go to the doctor during the pregnancy, so they may not be warned of those things. Usually, though, going to the OBGYN, a lot of times when they're doing those checkups on your child through the pregnancy, if there is a heart defect, a lot of times they see it and they can let you know ahead of time. So your family's going to know, and that's something you can ask. Let's say you walk in, you've got a 2-year-old in cardiac arrest. When you do your history, ask them if there's any cardiac history, and then just act like you normally would. So if they say yes, this child has cardiomegaly, for example, okay, note it and move on. We can't fix a lot of that stuff. You're not going to give a child nitro, that kind of thing. So CPR if they need it, get them to the hospital. All right, so before we get into the AEDs, let's talk about the numbers for CPR real quick. You guys, everybody's had CPR at least once, I believe, even if you're not current. The numbers really haven't changed. So let's see, if they say no, Should you maybe suspect trauma or abuse and call LEO? Use your best judgment. It's real easy to say that no concerned parent is going to tell you not to do CPR on their child, but some religious sects, and I say that SECTS, some religious sects don't want those interventions. So I forget which one it is. There's a Christian denomination that refuses to allow life-saving interventions at a BLS level like that because it's against their religion. They feel like if the heart stops, that is God's will, and the child or the adult or whoever, it's time for them to go. We have to respect that. That's not necessarily abuse. You don't need law enforcement for that. And they'll happily tell you, like, our religion forbids this. You know, they're not going to be like, if it's no, don't touch my kid, and there's no reason, that could be different. And it's really impossible to tell you unless you're in the scene. Yeah, it might be. I don't know. I have to go back and take a look. It could be Jehovah's Witness. It could be, oh God, what's the ones that don't drink caffeine? Might be Jehovah's Witness as well. But anyway, let's go over the numbers for CPR. Mormon, that's it. Thank you. Yeah, Amish too. Let's go over the numbers for CPR. We're going to talk about adults first. Adults are easy because the numbers are always the same. It doesn't matter if it's just you, if it's you and your partner, if it's 10 ambulances show up and they're all paramedics, great. The numbers are going to be the same. So it's 30 compressions to 2 breaths, all right, 30 to 2, and count out loud. That's not just a school thing. That's please, for the love of God, if you got somebody sitting there at the head waiting to give breaths, count out loud so they know when you're getting close to your 30. That also helps you keep your pace in mind because you can hear yourself counting. Which, let's talk about the pace. Anybody know what the pace for compressions is? How fast should we be doing them? Just don't sing Another One Bites the Dust. Families don't like that. All right, but there is a number range, and y'all need to know that. It's not every second. That's too slow. Definitely not every 2 seconds. That's way too slow. So we're talking about, let me kind of get you guys on track here so you can think about the numbers you're giving me. How many compressions in a minute do we want to give? Think about your pulse, right? Close, very close, JW, you almost had it. It's 100 to 120. So you want to go at least 100 up to 120 beats a minute. Normal pulse range in an adult is 60 to 100. Okay. So you're going to be kind of clocking along right at the top end of that range. The reason why it's 100 to 120, and it's going to be 2 every second, not 1 every second. And that's as fast as you want to go, because that would be 120 beats a minute. The reason why we pick that range is because when you start talking about children, right, the smaller the child, the higher the pulse. We talked about that in lifespan and development. The average pulse of a child, like a prepubescent 4th grader, 3rd grader, whatever, you're looking at somewhere around 80 to 120. You're still in that range if you're doing 100 to 120 beats a minute. An infant, you're looking at more like 100 to 150. So if you're doing 100 to 120, you're still in that range. That range, that 100 to 120, is a good range no matter what you're dealing with. So we only have to give you one set of ranges, as opposed to trying to make everybody know the pulse range. You say, all right, it's an adult, so they're going to do 60 to 100. No, it's confusing. So 100 to 120 beats a minute, 30 at a time, and then you're going to give your 2 breaths. How long do we have to give the 2 breaths? Remember, if I ask you anything that is time-based like that, what's the magic answer? 10 seconds. Very good. All right. And then the depth. Just know how deep you need to go on an adult's chest, which is at least, oh, I'm sorry. Yeah, at least 2 inches. There you go. Good job, Travis. All right, so those are your numbers. And then with the 2 inches on compression, make sure you come up all the way so that the heart can refill completely with blood. Um, very good. Now, again, do the 30 to 2, does that change with an adult? Does anything change that number? All right, what about 100 to 120 beats a minute? Does anything change that? Good. Okay. Now let's talk about kids. Remember, kids are they're the respiratory risks, right? They're the ones that are most at risk of choking, most at risk of SIDS or other issues where their respiratory system just shuts down. That's normally the way they go into cardiac arrest because whatever one system does, the other one's going to follow. If you breathe fast, your pulse is going to pick up. If you stop breathing, your pulse is going to stop too. And there's a physiologic reason for that I won't go into because it just really doesn't matter. Just know that they operate together. Um, so we still want you to do compressions first. You're still going to do CAB, but if there's enough of you, if there's 2 rescuers or more, you're going to cut your compressions in half. So instead of doing 30 to 2, you're going to do 15 to 2. And what that does is in a minute time span, you're going to get twice as many breaths. That's the whole reason that we're doing that. Is we're trying to keep their respiratory drive up. The other things to do with kids and the numbers. Let's say you show up to a child and he is unresponsive on the floor. You shout at him, nothing. You flick the foot or you pinch the shoulder, nothing. He's unresponsive, so we're going to check a pulse. Let's say he has a pulse of 50. All right, so you check it and you feel it, but it's a 3-year-old and they have a pulse of 50. What do you do next? Let's see if we'll leave it at that and see if anybody gets it. Okay, so you're going to check respirations. Anybody have different answers? Let's see what other people think. Kids are funny. All right, so check airway. What else? Anybody have any other ideas? This one will surprise you. Child is unconscious. You check a pulse of 50, and it's a 2. We'll say it's a 2 to 3-year-old. Okay, so we got to check respirations. Sternum rub doesn't do anything. Anybody gonna start chest compressions on this child? Okay, so we got a no. Anybody else? No? All right, it's 2 to nothing for no's. Anybody say yes? You know my follow on if you say yes is going to be why. There you go. All right, good job. I wanted to see if y'all got it. So yes, kids are weird. All right, remember, smaller the child, higher the vital signs, right? And I know we haven't gotten into it yet. Some of you guys work in EMS, so you pretty much would be tipped off to this one already. We haven't talked about shock, but I'm going to go ahead and kind of jump the gun, and I'm going to say this: children, when they decompensate, well, let me start it with this. Adults, when we start to go into shock and we decompensate, which means that our body can no longer maintain normal body function because we either lost too much blood or whatever. When we really start to kind of tank down and circle the drain, it's a gradual, steady thing for us. All right, for adults, you're going to see the blood pressure is going to start to drop while the pulse is staying sky high, trying to maintain the blood pressure, but it's not working, so the blood pressure is dropping. And then the pulse is going to start to come down, and we trend downward until we're dead. Kids are scary. Kids don't operate like that. Kids they will look perfectly fine. They'll have a little bit of a high pulse, but their blood pressure looks good. Their respirations are good. They're crying. They're uncomfortable, whatever, and then they're dead. And that's kind of the problem. So kids, when it comes to shock, they only have one mechanism for maintaining a blood pressure, and that is their pulse rate. That's the only thing they've got. As they get older, when you start to get to more adulthood, then your body starts to figure out, oh, I can constrict my blood vessels. I can release different hormones that do different things, and I can maintain my compensation better. Kids don't have that. They just have a pulse rate. That is it. So when that one mechanism fails, they go from looking great to nothing. And the easiest, we don't want to miss that chance. All right, you don't want to be caught on your heels basically when a child goes from compensated to dead in front of you. So when you're checking your pulse for children, you want at least one beat a second. All right, so there's not good enough to just have a pulse when you're dealing with kids. You want to have at least 60. So if you're checking the pulse for 10 seconds, you should be able to feel a beat at least once every second. If you don't, they need compressions, because at that point you basically have caught them right on the brink of going into cardiac arrest. Kids don't have a pulse that low. All right, that's the low range for an adult. Kids low end is like 80 or 100, or if they're in the infant range, you're looking at like 120 or whatever. If they're sitting at 60 or less, they are way at the end of that one compensation mechanism that they've got, and there is nothing else. So don't wait. Don't wait for no pulse. Go ahead and start doing compressions. Try to keep them from going to that point. That's what I was going to get at with that. Um, Kids are scary. Kids are scary because of that. But if you know that, if you can remember that when you see it, you can get ahead of it, and it becomes much more manageable for you in the field. All right. Anyway, let's talk about the AED. Anybody ever use one? Anybody that doesn't work on an ambulance ever used one? Sorry, Vicky, I had to throw that out there. Okay. Some of you have, some of you haven't. Anybody, has anybody never seen one? How about that? We'll see from there. All right, cool. So your AED, remember the AED is trying to fix the electrical issues, right? So the sooner we get it on there, the sooner we can try to catch and fix either VTAC or VFib. That is it. The AEDs are not going to diagnose a rhythm. A heart monitor that a paramedic hooks up, yes, because then they can look at it and everything. And even if an AED shows you a rhythm, because some of them have a screen, um, the AED is not saying, "Oh, this is a left-sided heart block," blah blah blah. So I want to, hey, do this. No, the AEDs say, "All right, is it VTAC? Yes. Okay, cool. Shock advised. Is it VTAC? No. Okay. Is it VFib? Yes. All right, cool. Shock advised." And that's how it makes its decision. If it says VTAC, no. All right, VFib, no. Then you hear no shock advice. And there's so many things that can be going wrong with the heart that would probably put a patient into cardiac arrest that you're gonna have to do compressions for. That the AED is gonna be like no shock advised. All right, so just know that the AED is looking for two things, and that's it. If it's asystole, no shock advised. If it's a normal sinus rhythm, no shock advised. So it could be either way. They could be dead. They could be perfectly fine. You put an AED on a person that's up talking to you, it's going to tell you no shock advised. You should put this on your patient as soon as you get it. If you're the one doing compressions, hopefully somebody else is there. They can put the pads on around your hands so that you don't have to stop compressions. There's only two times you're going to stop compressions. Both of them have to do with the AED. All right. When the AED goes to analyze, everybody clears the patient. Because if you're touching the patient, the AED sees your heart rhythm, it's going to say no shock advised, even though it probably should have shocked. If there's any feedback, if there's any issue where, like, even if it can't determine the rhythm, say it sees VFib in the patient, but it sees sinus tach from you because you're freaking out and your heart's racing, it may not be able to differentiate between the two rhythms. All it knows is that it's not what it's looking for. And it'll say no shock advised when it probably should have. So you're going to clear for the analyze, and you're obviously going to clear for the shock because I don't know if you've been tased, but this is much worse. You don't want to ride this lightning. For children, Putting it on, when you put it on, if you're by yourself, kind of is determined by whether or not you saw them go out or not. If you show up to a child in cardiac arrest and nobody knows how long he's been down or whatever, then you're going to go ahead and start doing CPR first after 5 cycles or 2 minutes. Then you're going to put the AED on him. If you're off the clock, call 911 so that you can actually get an ambulance out there. If you're on the clock, well, throw them in your truck and let's go. If you can use a manual defibrillator, great, but those are a little bit, most of the time your manual defibs are part of the monitors, and your monitors are out of your scope as EMT basics, so you won't really have access to that. Oh, you need to shave a pad. Okay, yeah, so let's go ahead and start talking about that. What are some things that we need to be careful of with AEDs? Not necessarily for safety, but just to make sure that they work properly. And one of them is already on the chat. So I'll mention that one while you guys are typing other things. Hairy chests. Anybody ever see the 40-year-old virgin? If they look like they're smuggling a dead animal in their shirt, then you're gonna have to get rid of some hair. There's a couple ways to do it. An easy way to do it is just put a set of pads on and then promptly rip them off. Like if you've seen those videos, I hope that guy got paid a lot of money. But you can do that. You can put a pair of pads on there and then rip them off and have it take the hair. Or you can use a razor. My only word of advice is make sure if you're going to do the pad trick, because it's much faster, if you're going to do the pad trick, make sure you have another set of pads, because that first set's going to be unusable after you shave the animal with it. AEDs that are actually serviced and maintained will either have an extra set of pads or they're going to have a razor. They'll have one at least. Some of them will have both. If you're going to go the shaving route, you don't have to shave the entire size of the pad, and it doesn't have to be clean shaven, right? We're not making military baby smooth skin out of somebody's chest to put a pad there. You really only have to have enough skin for it to stick, and you want it to be where if you look at a set of pads, the wire that runs into the sticker is going to stop somewhere. Usually it stops at the bottom of the pad. Sometimes they go to the middle. That's the spot where you really want to make sure that it sticks. If the edges of the pad are getting caught in hair, big whoop, that's not where the electricity is coming from anyway. You want to make sure that the middle section, which is about an inch or two diameter, that's going to be what you want really sticking to the patient. Let's see what else we got. All right, 80 pads. Yep, said that. Okay, expiration date. Good. You guys that work on fire departments, if you were in fire prevention, you're going to want to check the expiration dates on the pads. On your truck, check it every day. If you're on an ambulance, something of that sort. All right, if you have a bra, you need to remove it. That's correct. Make sure they aren't sweaty. Have to dry them off. All right, Vicky. Let's talk about the sweat for a second. Let's go into the sweating and water. If you have a patient that's in the water, let's say they had a diving accident or they're drowning accident, and you show up because the people that were in the pool yanked them out, now they're on the side of the pool, but they're in a big ass puddle of water. Do we want to shock them like that? No, no. Rhetorical question, for I already know the answer. No, we don't, right? Because electricity is not going to really play well with the water. So you want to get them as close to dry as possible. Now, let me ask you this though: if somebody's having a full-blown heart attack and they've gone into cardiac arrest, what's one of the signs that you're going to see? Remember, a sign is something you can see. So think about what you might have a patient. They're going to be cold and clammy, right? What's clammy? Kind of wet, wetting. Good. If they're in cardiac arrest like that, they're going to be diaphoretic is actually the term that we're looking for here. That means sweating and it's profuse. So you're probably never going to get your patient completely dry. As fast as you're wiping the sweat off, they're just putting more water out. And it's because their blood is not flowing. So the plasma is leaking out. That's what's happening. It's coming out of the vessels in the skin. So it's not really sweat as what we normally do. You can use alcohol prep, but that's going to take a whole lot of time. Just grab a sheet, wipe them off. They don't have to be completely dry. You just want to make it to where you don't have a bunch of standing water between your pads. All right. What else? What else are we looking for? What are some landmarks that we want to avoid? Especially think older patients. And I'm going to move slides while y'all are thinking about that. Other things that we may want to avoid. In fact, I'll leave it on this slide because one of them's on there. Actually, two of them are on there. Jewelry matters if it's on the pads or near them. Huge gold chains, you might want to move them up closer to the patient's face, that kind of thing. All right, there we go. So medical patches and pacemakers. If somebody has a pacemaker, that tells you that they already have electrical issues with their heart, right? So it would stand to reason, the first thought would be, well, we don't really have to shock them because the pacemaker's there. But the problem is if they're in cardiac arrest, that pacemaker may not be working, right? So the big thing about that is we just want to put the pad somewhere other than on the pacemaker. Older pacemakers, up to a few, I don't know, maybe 5 years or so ago, used to leave a big lump in the skin. You would see it. The AHA video always said smaller than a deck of cards. It was just like a big whelp on somebody's chest. So you would just put the pad somewhere else. You can move it anywhere in that area. You can move it up, down, to the side, whatever, just not on the pacemaker. New pacemakers have gotten so small you may not even see the lump. So if you don't see it, don't worry about it. Just put a pad there. If it fries the pacemaker, well, that means that it wasn't doing its job anyway, so big deal. Transdermal medication patches, those can be pretty much anything. They could be nitro patches, they could be fentanyl patches, could be, I don't know, nicotine patches, right? Anything that gets through the skin and is designed for that. So what I want you guys to be careful about with this, the patch needs to come off, all right? You should be wearing gloves. You should be wearing gloves on any call that you're on. So just grab the patch and rip it off. That's perfectly fine. Wipe the skin, put the AED pad on. But I want you guys to be very careful. If you get fentanyl on your gloves, congratulations, the gloves protect you. But if you turn around and scratch the side of your face and you put fentanyl on your skin on the side of your face, you may be laying there on the ground with respiratory depression as well before you know it. So if you do that, consider it contaminated gloves. Treat it like blood. Don't touch yourself. If you want to swap gloves when you can, that's a pretty good idea. That way you don't put nitro or fentanyl on your skin and suddenly you're having vital signs crashing because you don't need those meds, right? All right. Have you ever been shocked by a patient's pacemaker? No, I haven't. I can't. That's one thing I can say is I try not to get shocked. I've been shocked by a car battery, and I've been shocked by a taser because my chief made me. It wasn't fun. But no, I haven't been hit by a pacemaker or an AED. I'd rather not. Well, I bet. Yeah, they may feel it when those things are popping off. It's not like getting hit with an AED, but they'll know. All right, it's 8 o'clock for me. It's 7 o'clock for y'all. Take a 10-minute break, and we'll pick back up with patient positioning. And we're going to start to kind of move quickly through some of this. So just bear with us because some of this stuff is going to be mostly boot camp level things that we're going to deal with when you go for your hands-on portion. See you in 10. Okay, so I'm going to try something. We'll see if tech wants to work for me tonight. If you guys don't hear anything, I apologize for the massive fail, and we'll get it to work in future classes. All right. So, quick quality check. How was that? That was our first time, at least on my computer, doing a screen share with a video. Were you all able to hear it good and all that? Sweet. Okay, awesome. Just want to make sure because I'm going to start, at least for the classes that I teach, and I know Chris will do the same thing. Um, we can start showing videos ahead of time of the boot camp. Can I show you guys how certain things may play out, like your scenario, your assessments, for example, and funny stuff like this to try to not make it so dry, because I know that nobody. This is great sleep aid. Having to sit here and listen to people drone on about medical stuff all night long. All right, so let's talk about actually going through your how you're going to do CPR. First of all, if somebody's face down in a ditch, can we do CPR on them as they are? No, not really. We can't do an assessment. We can't do anything when they're face down or in any weird position. Our goal is to get them into a supine position, which is laying on their back. All right. So whether you're worried about CPR, whether you're worried about just somebody unconscious or drunk, hypoglycemic emergencies, diabetic emergencies, altered level of consciousness, whatever it is that we're dealing with, they need to be on their back. All right, you can't expect the patient to have a good airway if they're laying face down. So get them on their back. There'll be times when we want them on their side. That's a little different. We'll talk about those. But when it comes to CPR specifically, they definitely need to be on their back. So roll them. You can use a longboard. When we get to trauma, we're going to start bashing the longboard pretty hard because we're trying to get away from it as EMS. Um, it winds up causing a lot more harm. We've lost patients because we stuck them on a backboard, that kind of thing. But if you need to use it for patient movement, that's different. All right, that's not an intervention. You're not strapping them to the board and keeping them there or whatever. You're just using it to kind of get them out of wherever they're at into a better position. Even if they're on a bed, that's a very great thing. Vicky, good job. If they're on a bed, you can either move them to the floor or you can just quickly log roll them, put a board under them, and then start doing your compressions right there on the bed. It's whatever you need to know, whatever's going on at that point. But if you're not using the longboard as an intervention, where you're trying to maintain spine stabilization, then you can take the board off. If that's why you put the board on them, though, is because you're worried about damage to their spine or their hips or legs or whatever, only the doctor can take it off. So keep that in mind. That's one of the reasons why we try to get away from having everybody do it. So you roll your patient over. You're going to check their level of consciousness. Hey, are you okay? There's nothing. They're completely unresponsive. We're going to check a pulse. Check the pulse on your side of the patient. Because at this point, we still don't really know why they're out, right? They could be down because they had a syncopal episode. They could be down because they're diabetic, because they are high on drugs. I mean, you never know. I mean, and even that may not have been intentional. But one thing is pretty common, and that is when you first start to come back from being unconscious, you don't really know where you are for a second. You don't know who it is that's leaning over you. You don't know if you're being attacked, and your fight or flight kicks in. So if you're leaning over your patient, reaching across them to feel their pulse, and a lot of people do this, you reach on the other side of your patient and they come up swinging, guess who's right over them and may not be able to get out of the way in time? You don't want to be that person. All right, so check the pulse on your side. So if they do start to come out of it, if it's not cardiac related and they start to wake up, they freak out because somebody's standing over them, they come up swinging, just sit up. You're not leaning over them. Your center of balance, your center of gravity and everything is not directly over them. It'll be better for you. Yeah, and we'll talk about Narcan in a little bit. I'm gonna not get on a soapbox, I promise, but our goal is not to wake our patients up. All right. Also, if a patient's unresponsive, check the carotid. Don't waste time with the radial. All right. they start to go unconscious, you're probably going to lose a radial pulse, but they may still have a pulse. You'll feel it either in the femoral or in the carotid. Just check, go straight for the neck if they're unconscious. If there is no pulse, we're going to provide compressions. How many times are we going to do compressions? What's our number? Not 120. No, that's the upper end of the rate. I'm just wondering how many times are we going to compress before we stop compressing and do your airway? Nicole got it. 30 times. All right. So 30 compressions. There you go. So you feel for a pulse. They don't have a pulse. You immediately start compressions going to 30. All right. Once you hit 30, then you open your airway with either the head tilt chin lift or the jaw thrust if it's trauma, and we'll talk about that when we get to the trauma module. So you're going to open the airway, and then you're going to give 2 breaths, and make sure that you don't just speed racer right through it. All right, you're not in a race with the breathing. You're not even in a race with the compressions. Again, we're trying to maintain what would be a normal vital sign range for somebody that might have at most just gone for a small jog or whatever. So it's now you're not flying through it. You're not trying to hurry up and do as many as you can. That's not what we want to do. Same thing with the breathing. When you give your compressions, make sure that you go with that good speed, 100 to 120 beats a minute. And again, that's just a range that fits every age group. That's the reason why those are the numbers. Okay. Yes, they're a little fast for an adult. They're technically a little slow for an infant, but they're still close enough to the range of every age group. So you can just say 100 to 120 beats a minute, or not even say it. If there's a person dead on the ground in front of you, you can just do 100 to 120 beats a minute. Doesn't matter what their age is, you're in the right range. Here's a couple of things about chest compressions I want you guys to keep in mind. First of all, when you are doing your chest compressions, if you're doing them proper, you're getting blood flow. That's the whole point, right? We're moving blood around the body. If your patient is in cardiac arrest, that means their blood pressure is bottomed out. You have to have an active pump to make the blood pressure have any kind of value to it. So if there's no heartbeat, there's no real blood pressure. There's a diastolic, there's blood still in the pipes, but there's no systolic blood pressure. I want you to think about the anatomy of the heart for a second. Your coronary arteries come off of your aorta right at the very base. So this is the part of the body that's got the most pressure. When the left ventricle pushes, the aorta has the highest systolic blood pressure at any given time in the body. The pressure only drops the farther away it gets. It just stands to reason, right? That's why the aorta is such a big pump at the base. It's also why the valve leading to it, or leading between those, like the left atrium and the left ventricle, is a bicuspid valve. It's just a stronger valve. It's meant to handle that kind of pressure. But what's not meant to handle that kind of pressure is the coronary arteries. They're tiny. They go right off the aorta and they immediately start feeding the heart. So these are not big vessels that start to kind of come down in size and everything. They're already small right at the base of the aorta. So what stops the heart from just blowing those arteries into oblivion on the very first time it ever takes a beat? The amount of pressure that goes through the aorta would just completely annihilate the coronary arteries if not for a valve. All right, I don't expect you guys to know the name of the valve. That's out of the scope of a EMT. It's really, even the paramedics don't give a crap what the name of it is. But know that there's a valve there, and the blood pressure has to be over a certain amount to get past that valve. That's the check that stops the pressure of the aorta from just completely blowing up the coronary arteries. That is why 30 compressions is so important. If you show up to a patient from your very first compression, you don't have anywhere near the right blood pressure to get blood in the coronary arteries. As you do compressions, and they have to be good ones, you're going to slowly start to build your systolic blood pressure up. You have to get it past a threshold or no blood will ever make it into the coronary artery. So if it's a heart-related problem and you stop too early, or you're doing bad compressions, or you're doing them too slow, or whatever, the blood pressure is not going to reach the point it needs to get the blood into the coronary arteries. And then all those compressions are wasted. All that energy you expended is wasted. The heart doesn't get anything that it needs. So that's really important. All right. So there's only two things that will stop you from doing compressions to 30. All right. What are those two things? And they both come from the same thing. So the question is, what stops you from going to 30? If now that you know why it's so important to get at least 30 compressions without a break, what's the one thing that can stop you from doing compressions? Like if you're at 12 or 13, all right, if they wake up, sure, if they come up swinging, but we're talking about somebody who is legitimately in cardiac arrest. They're not going to wake up. What's the one thing that can stop you from going to 30? And it's for two different reasons. Anybody? We talked about it earlier. What do you not want to be touching your patient during? There you go. The AED. All right. So the AED is the only thing that will stop you from doing compressions. If somebody shows up and says, "Hey, I'm here to help take over. I'll take over compressions." Great. They can wait until you're done with 30. But the AED will stop you. And that's the only time it doesn't matter where you're at. Don't keep going to 30 if the AED is trying to stop you, because it doesn't care where they're at with a pulse. It's going to check, it's going to analyze when it wants to analyze, and it doesn't care what you're doing. So once it starts, get off the patient. That's one reason to stop doing compressions before 30. The other would be for it to give a shock. Again, if it determines that it needs to give a shock, the shock takes precedence. So let it pop. All right. As soon as it does, immediately get back on your chest compression starting at 1. So if you're at 17 or 18 or whatever, it says shock, press the shock, all right, stop, clear your patient, press the shock button, patient flops like a fish for a second, and you immediately get back on chest compressions. There is no gap, there is no waiting. As soon as you hit shock, start compressions and start back over at 1. All right, good. As you can see from the picture, your heart sits in the center of your chest, kind of the lower half of the chest of the breastbone. That's where we put our hands. And the heart kind of angles off to the patient's left side. There's a little bit of the population that's backwards, but for the most part, that's where it goes. That is why when you put your pads on your patient, you're putting it on their upper right chest and their lower left. If you're going to look at it from like this picture right here, it's your upper left and bottom right. But for the patient, it's backwards. Every time you see a picture of a patient or you're talking about the heart, your left and right is reversed because you're referring to the patient's left or right. The easiest way that I can remember to tell people to do this when, home dude's laying dead on the ground and you're freaking out because, oh my God, I'm trying to work with a dead guy, or this is my first cardiac arrest, or, whatever. The pads go like you're reading a book. All right. You start at the top left of a page, you end at the bottom right. That's your point of view. So that's where you're going to slap those pads. Yes, it's the patient's upper right, lower left, but for you, it's upper left, lower right. Just think of it like you're reading a book. New pads, some pads actually come and they're already connected. They have this little strip between them, and it just goes however it fits. Even if you flipped it upside down, it would still be in the right spot. That's just the way it is. Let me ask you this. I didn't bring this up in the AED portion. All right, so you have the pads. If anybody's seen an AED, they've got the pictures on them, right? One pad shows that it goes on the patient's chest. One pad shows that it kind of goes down on the abdomen. How important is it that you get those in the right spot? As far as like the chest pad going to the chest and the ab pad going to the abdomen. What if you flip them backwards? Is that important? Where the chest pad is now underneath the arm and the abdomen pad is up on the chest? Does that matter? Okay. So we got one for don't swap. Anybody say different? And I'm not saying you're wrong. I'm just curious. This one's kind of a trick question, but let's see. Just follow the pick. All right. But let's say you're in a rush and you throw it on there and you realize, oh crap, I got these backwards. So the answer is a little tricky. It really depends on your AED. If you're using one of those old dinosaur AEDs, it's actually they call them monophasic. That means that all of the shock is going to go from one pad to the other. And then if that's the case, it matters. All right. You want the chest pad to be on the chest and the ab pad to be on the abdomen because the shock is going to come from the chest pad 100%, 300 joules, whatever that is going to shock with, is going to go from that one pad through the heart to the back to the abdominal pad. Now, look at the picture and imagine, like I said, how the pads are placed. If you've got one in the patient's upper right, that means that it's going to be over the purple lung on the top half. And then the one on the bottom left of the patient is going to be kind of down on the left side of the chest where it shows the muscles and the diaphragm, and the heart's kind of pointing toward it. On a monophasic AED, all of the shock is going to go from one pad to the other, and you want it to go from the top of the heart down toward the apex, which is at the bottom. So it did, yes, absolutely. Those old AEDs mattered, and that's where the pictures came from. All right, that's why they were there. But there was a problem with that. We found out that if we were going to smack somebody's SA node directly with 300 joules of energy, all from one side, sometimes that does more harm than good. So they stopped doing that. They made it to where most of your AEDs now are biphasic. So half the joules come from each pad. Half is going to come from the chest pad, half's going to come from the ab pad, and they're going to go toward each other. So they're going to cross, but they're going to be half the strength, and each one is going across the heart. So with that, if you're using any AED that's been made in the last, I guess at this point, probably closer to 10 years, it doesn't matter. The pictures are still there to show people where they go, but if you get them backwards, it's okay. If you put the chest pad at the ab and the ab pad at the chest, that's all right. What is important is that you don't reverse them on the sides of the body. You still want the path between the chest to go the length of the heart. All right. So if you look at the picture of the heart, yeah, a lot of them, the batteries are probably dead by now, so you really don't see them in service anymore. Even monitors, a lot of the monitors that paramedics carry, they took the handles, like the actual pad or the I don't know, the whole, like you see it on TV where they rub them together and they're like, all right, shock. And please, if you do have paddles, don't do that. They break them. But anyway, you want the pads to send the shock the length of the heart. So if you see how the heart sits and kind of angles off to the left, that's basically showing you that like it's pointing to the pads. All right, you want to put one pad above the heart, one pad below the heart, and it's going to be patient's upper left. I'm sorry, patient's upper right, patient's lower left. That's why we put the pads there. So you don't want to make it where the pads go across the heart. You want to make it where they follow the length of it, because that way more of that shock hits more of the pacemakers, right? The length of the heart, you're going to catch the SA node, the AV node. Both branches are going to get more of the shock. It's just going to work better. If you flipped it sideways, you would hit the AV node fantastically because it's right in the middle of the heart. But the SA node, which is the primary pacemaker, is only going to get part of the shock, and you're going to do a massive blast to the inferior side of the heart, which we don't always want to do that, because if we're following this up with nitro and we screwed up their inferior side, the nitro is going to do more damage to them. Anyway, just a thing I wanted to point that out. So new AEDs, you don't necessarily have to follow those pictures to the T. Just make sure that you get them in the right corners of the chest and abdomen. All right, that's just showing you your compressions. This is your airway. Head tilt, chin lift on the left. If there's no sign of trauma or no concern of trauma to the neck, You can do that. That is a good airway. If they have trauma, if there's any risk that if you're concerned at all that there might be damage to their neck, you're going to do a jaw thrust. All right. So, and that's actually harder than it looks. The jaw muscle is pretty strong. You're going to hook your fingers underneath their jaw, kind of under the ears, and you're going to use your thumbs as leverage against the cheeks, and you're going to lift their jaw up in this sense because he's laying down, but basically forward. You're kind of jutting the jaw forward. It lifts the tongue off the back of the throat. That's the only purpose of that. That's the only thing it does. If there's anything else wrong with their airway, that won't fix it. So same with the head tilt chin lift. Those are strictly to get the tongue up. The only thing, and the reason I'm foot stomping this is because when we get to the boot camp or when you do your psychomotor evals or whatever, or even you get out to the field, if your patient has snoring respirations, that means the tongue is flapping on the back of their throat and it's a partial occlusion of the airway. So a head tilt chin lift or a jaw thrust will fix that. If there's any other problem, if it's they're regurgitating stuff, there's blood in the airway, broken teeth, whatever, these maneuvers don't do anything for that, right? What would fix that? If they have a bunch of crap in their mouth and you know that the jaw thrust and the head tilt chin lift aren't going to do anything, what would do that? We want to get that stuff out of there, right? Have y'all had the airway management chapter yet? Bueller? Anybody with me? Okay. All right, there we go. Yep. So we're going to suction. Just be aware, you got to do a maneuver that fixes the problem. If the problem is that they've got a mouthful of fluid, you're probably going to want to do a head tilt or a jaw thrust, yes, but just know that that's not going to fix the problem. The problem is that they've got a bunch of crap in the mouth. You got to suction it out. How long do we suction for if you got to do this? And again, this is that magic time limit. Anytime I ask you a time limit, it's not 15. 10. There we go. 10 seconds. All right. Yeah, until it's clear real world, but for testing, it's 10 seconds. All right, suction up to 10 seconds. After that, and really even by the book, it's not wrong information to say 10 seconds. What they're saying is suction for up to 10 seconds, then provide some ventilations, and suction some more, and then provides, that kind of thing. But really and truly, if you've got a mouth full of crap, the ventilations aren't really going to do you any good. So suction until it's clear. All right, there you go. Yeah, y'all, the rust is starting to knock off. Suction on the way out, not on the way in. No more than 10 seconds. Very good. All right. So we talked about opening the airway. As soon as you do that, you want to, well, I said before we even get to that, remember, make your choice wisely. If there's trauma involved, you're going to do the jaw thrust. If there's no trauma, you can do the head tilt chin lift. That fixes the tongue. So you're going to suction out any vomitus or anything else from the mouth. That's going to fix anything else that may be blocking the airway. All right. The recovery position, you can't do CPR in the recovery position. This is if you don't need to do compressions. All right. If you got a pulse back or, they're just unconscious, but they have a mouthful of fluid, instead of just sitting there suctioning all day long, you can kind of roll them on their side and let the fluid just come out. That's okay. All right, so I'll skip this. These are your barrier devices. The BVM. I'm gonna give you guys a BVM class at boot camp, and I know that sounds dumb, but you'd be surprised what information is not taught. And I'm not saying that as far as Chris is concerned, but just in general, like they don't talk about the PEEP valve a lot of times. I'm pretty sure did Chris go over, because I didn't listen to his lecture. Did he go over how much of that bag we're supposed to squeeze for any given breath? Do we squeeze the whole bag like what you're seeing in this picture? Right. Once you see chest rise, that's when you stop. Usually it winds up being a little bit less than half of that bag. Because of that, a lot of your systems out there now are just stocking pediatric bags so that you can squeeze the whole bag because that's what we've always done. And it sucks that that's what we've always done because what that does is if it's an adult, you fill the lungs, congratulations, and then all that other air goes into the stomach. And if you've ever, any of you guys have ever had the great fortune of working cardiac arrest where somebody had a basketball sized belly because of gastric distension where all that air was going into the stomach and then it comes out, God forbid, that is the worst smell I've ever experienced. I've smelled burning flesh. Um, that is the pits to me. We had to take an ambulance out of service for a week to fumigate it after somebody belched up all their stomach contents because of all that air. Um, it's bad. It's bad. It was bad enough that me and the paramedic had to evacuate the ambulance and do CPR outside the box because we were about to throw up everywhere in the truck because of the smell. So yeah, it's important. Don't overinflate your patient. With an adult bag, there's no relief valve. If you overinflate your patient, it's going to go somewhere. If you've got a good seal like what that patient has in the picture, it's going to go into the lungs, and then it's going to go. Everything else is going to go into the stomach. Um, if you're using a pediatric or an infant bag, depending on the size of your patient or whatever, they have a PEEP valve. It's an overpressurization safety mechanism where if you overinflate the lungs, all the extra pressure just kind of pops off the PEEP valve and goes out into the room. So you don't pop the lungs. It's the whole purpose of that. Um, and then also keep in mind if you overinflate and you start putting all that air into the stomach, think about your anatomy as far as where does the stomach sit related to the diaphragm. Remember, your diaphragm is kind of like a frown, right? It looks like a it's like a one of those pogs, if you remember those when we were kids, where you could flip them upside down or inside out, sit on the table, and they would pop themselves up. That's kind of what your diaphragm looks like, and your stomach sits right below it. So when you try to breathe and the diaphragm contracts down, um, what's going to happen is that's the stomach being full of air is going to stop the diaphragm from moving like it should. So that is going to stop your patient from taking a very good breath. On top of that, every time we breathe, because we actually breathe by negative pressure, not by positive pressure, which the BVM is positive pressure, you are pushing air in. Every time you give a breath, even if you did it perfectly, not all that air is going to come back out. Some pressure will remain in the lungs. So the longer you do it, the more that pressure is going to build up. And if you're doing it wrong, it's going to build up that much faster. All right. But if you do, even if you're doing everything right, you eventually will get to a point where the lungs don't deflate anymore. And all that pressure is going to put pressure on the heart, which means that if you were to get a pulse back, the amount of pressure in the chest is going to stop the heart from beating because there's no more room for it to do so. So the BVM is kind of like the best thing we've got right now. It sucks in general for long term. They really need a vent if they're not breathing for very long, if they're not breathing for a long time. This is all right. Hopefully we get them to the hospital. But the point that I'm trying to make is that if you do it wrong, if you just throw the BVM to the new guy and say, "Here, breathe for him," because I don't want you to do anything else, you really run the risk of hurting your patient. Our instructor in paramedic school said that a better idea is to give your BVM to somebody who's actually got some experience because it's a lot more important than people give it credit for. All right, if your patient has a stoma, you can actually pop the mask off and just connect the BVM to the stoma. All those connections are universal, so they'll fit perfectly, no matter how they work. Like if somebody gets an ET tube from a paramedic, you just same thing. You pop the mask off, you connect the BVM to the ET tube, it just fits. It's great. Um, Same thing. And if you're going to suction your patient with a stoma, suction the stoma. All right, because that's where they're getting their air. It's not going through their mouth and nose at that point. So if you suction the mouth, you kind of wasted your time. If they don't have the tube, you can use a child's mask and just put it over the hole in the neck. That is a pretty gnarly looking picture. All right, we already talked about this. This is stuff that we did. We're going to start skipping through a lot of slides here because we just went over CPR. So one rescuer, 30 to 2. Does it ever change? Nope, not for one rescuer. Good. Does it ever change for an adult? Well, it's one rescuer, not, and even if it's a kid, still 30 to 2 if it's just a one rescuer. Same thing if it's an adult. So one rescuer and adult, those numbers are set in stone. It will always be 30 to 2. The only time it changes is if it's a kid and it's 2 rescuer. All right. That's it. It's always 30 to 2 is usually what you're going to wind up doing. All right. 2 rescuers is always preferable to 1 just because you have a partner that you can swap off with and not get tired. It's much better for you to swap every 2 minutes and never get tired than it is for you to try to just power through it until you're exhausted and then try to recover, because it takes a lot longer to come back from fatigue than it does to just never get there in the first place. So switch every 2 minutes, even if you're not tired. Don't wait until you're exhausted and then be like, oh, I can't do it anymore, because you're going to be out of it for like the next 20 minutes. Active compression, decompression, CPR. There are some devices that are like suction cups and you put them on the chest. And so you're going to push down and pull up. It's physiologically, there's some things going on that actually helps. Whenever you pull up, your patient's actually going to kind of suck air in. So you're getting a little bit of a ventilation with every compression when you use that. The only problem is you're going to wear out a lot faster. There are the Lucas devices. Those are some other things that are out there. Let's see, you got the Lucas, what's the other one? Auto Pulse is another one. Those are great. Anybody ever use them? Those of you that have been on trucks, have y'all ever used those or just seen them? You've used one? Wow. Okay. We carried them. I just never got to use one. My partner always was like, I don't want to use that, just compressions, which sucks. When they first came out, they did kind of suck. If they were the least little bit out of alignment, they didn't work. So, first bump you hit on the road and they'd mess up. They've gotten a lot better. So, okay, good. So you guys have seen them in use and everything. Yeah, New Orleans has them. They've gotten a lot better. So if you've got it, use it. All right, that makes your life a lot easier, especially if you're on an extended transport, or let's say you're fire based and you're not the transport, you're waiting on an ambulance, or you're stuck on scene doing compressions for a while. Just set the Lucas device up and let it go. The impedance threshold device, or ITD, this is a valve device placed between the endotracheal tube and the BVM. So remember, I was telling you guys about overpressurizing the lungs or letting too much air get in, because if it gets pushed in through positive pressure, it may not all come out. So the ITD helps kind of stop that from happening, and it allows you to do better quality CPR for longer, whereas you might have started to run into those positive pressure issues that I talked about with the BVM. That helps stop that from happening. A lot of places don't use them because more and more hospitals have popped up, even in rural South Mississippi. Poplarville has an ER now that they didn't used to have. So when I first became a firefighter, if I was doing CPR, I was doing it for almost an hour while we went to Hattiesburg. Once they opened that hospital up in Poplarville, for better or worse, because sometimes I'm not talking crap about that hospital, but sometimes those really rural hospitals, they see so little that sometimes you kind of wish they weren't there. That way you didn't have to stop there. But you're not always doing CPR as long as you used to. All right, so that one on the left, that's your active push pull. Like I said, it's like a big suction cup. So you're using that to do your compressions rather than hands directly on the chest. Your mechanical piston device, that's your Lucas device, your auto pulse. There's your example right there. You basically slide that under your patient, and that white piece is what's going to do the compressions. So you want to make sure that, if you've got this, they're battery powered. Make sure your batteries are good. So if you're on the truck, when you go to check the battery and your monitor, check the battery for that as well. And a lot of us, when we have those, we typically have a rotation of the battery. You put one battery in the auto pulse or the Lucas. You have one battery sitting on the shelf next to it as a backup, and your third battery is on the charger inside for the next shift. All right, infant and child CPR. For children, the only real difference besides the numbers, which, like I said, we already beat that to death. But if they're small enough, you can do one-handed compressions. But you're going to do it the same way. All right. So you put one hand on the ground to support your weight, get comfortable. Your other hand goes on the patient's chest, and you're giving compressions if they're small. If they're a 12-year-old linebacker, or something of that sort, or you just vertically challenged, 90 pounds soaking wet, you may still need to do two-handed. It's whatever's comfortable, whatever allows you to give the best compressions for the least amount of energy, especially if you're going to be doing CPR for a while. If there's two or more of you, you cut your compressions in half to 15, and that way you're giving twice as many breaths. So as you can see here, the reasons why kids go into cardiopulmonary arrest is because of respiratory issues. And this can be injury to their chest if they're in a car accident. Infections can do this. Foreign bodies, which I was horrible about swallowing peppermints whole as a kid. I think I had 911 called on me at least twice because I kept choking on peppermints. Submersion, electrocution, and submersion can be accidental too, right? I remember, again, kind of not really giving, this isn't a war story. It's more of I was an idiot as a kid and didn't think about this, but the house that I grew up in, we didn't have showers. We only had bathtubs. So I would get into the bath, and then I'd be tired and start to go to sleep. So I'd sit back on the nice and warm in the water or whatever, and I'd pass out. Very, very dangerous, because if I would have relaxed and slid down in the tub, I would have drowned. But thankfully, still here. Electrocution can do it, poisoning and overdose, and then SIDS. SIDS, I think we may have some slides on that toward the end of the chapter. The big thing about SIDS is that we still don't know what causes it. That's just sudden infant death syndrome, and it is respiratory. The respiratory drive just stops. And we don't really know what it is. I personally, it's just my idea. I could be way off the mark. I have a feeling that there are some scents out there that will do it, some fragrances, that kind of thing. Because I know that I myself, like if I smell something, I have to make myself breathe, even as an adult. Like it'll clench me up. I'm not allergic to it. It's nothing of that sort. It just, I don't know what it is. It's something about once I smell it, I have to make myself breathe. It could be anything. It may be that that the brain, because breathing is autonomous. Yeah, it could be that something in the brain just stops triggering the lungs. We really don't know yet. That's the only thing. Determine unresponsiveness, just like anybody else. This will be the first thing you do, because that determines how you're going to go through your assessment. Check for your breathing and a pulse. Still shouldn't take any longer than 10 seconds. And remember, just because they have a pulse doesn't mean that they don't need compressions. It's got to be at least 60 a minute. If you don't feel a pulse every second, they're getting compressions. Foreign body obstruction is common. Know the Heimlich maneuver. Know how we do that. The big thing about the Heimlich maneuver, the cool thing is that that's one of the few things they get right on TV. Anybody ever watch like a medical drama or something like that, and you can't get into it because what they're doing on screen is so outlandishly horrible that, and there was a fire department chronicle thing where he started picking on 911, like the Lone Star. Those are pretty funny if anybody's seen those. But I will say that, at least they get the Heimlich right, thankfully, on TV. The only thing I want to say is keep your own safety in mind, right? So if you're going to do Heimlich, particularly on an adult, place yourself in the position, kind of like a running position, where your leading foot, if you were on that whole on your mark, get set kind of thing, put your leading foot between your patient's feet. Um, that does a couple things. That turns you a little bit so that when you're actually doing the Heimlich maneuver, their head is gonna, if they hit you, they're gonna hit you in the side of the head, not in the face, which would be bad. But usually their head's gonna kind of go to the side of you if they're losing consciousness or anything and they're starting to go limp. Secondly, if they get to that point where they go limp and they start to fall out on you, you can guide them down your leg to the floor. If you're standing squared off behind them and they go limp on you, they're going to pull you forward with them, probably hurt your back, and you're not going to be able to do anything after that. For children, you're going to do the same thing. If there's a significant height difference between you and the child, you may have to get on your knees to kind of get at the same level. And then for babies, like actual infants, it's 5 back slaps, mama style, whack them in the back between the shoulder blades for 5, flip them over, do 5 of your chest compressions, flip them over, 5 back slaps, and you're going to keep going back and forth. All of your choking is going, all of your instances of this, you're going to do it until they either A, they cough it up, whatever it is they're choking on, or B, they go completely unconscious on you. If that happens, you're going to lower them to the ground, start CPR, and every time you go to do your airway and breathing, look and see if you can see the object. If you can, get it out. If not, don't try to do a blind finger sweep, because if you accidentally push it further down, you've kind of reset the problem and all of your progress to that point is gone. What about if they're coughing? Let's say you show up to a child coughing and there's a partial occlusion. All right, they've choked on something, the object is still in their throat, but they're able to cough, they're able to cry. Do we give them the Heimlich, or what do we do? That's a good question. I'll answer that as a follow-up to this one. So let's say they've got a peppermint stuck in their throat. You're responding to 2-year-old Rob Roy, the idiot that can't eat hard candy without choking on it. But it's not a full block. All right, I can still breathe. I'm just coughing a lot. What would we do? Would you do the Heimlich or anything else? And I don't want you guys to think of these as wrong answers. I just want you to think and kind of put out your ideas. What would you do? Back pat. All right, that's a good one. What else? That's not wrong. That's a good one. Tell them to keep coughing. That's a good one. Absolutely. Because the cough is a response. It's a body response, right? They're trying to cough up what it was. So the coughing may help. I guess the big thing is don't necessarily do the Heimlich. If they have a partial occlusion, that means air can get around it. So the Heimlich's not going to do anything, right? When you hit the gut and you push all that air up, yeah, the finger sweep, if you can't see it, is frowned upon. If you can see the object, by all means, flip them upside down. Don't do that. If you're gonna do the Heimlich on a baby, you can angle their head down to let gravity work for you, yes, but you're not shaking them to get lunch money. Yeah. So the big thing is just don't do the Heimlich. If it's not a full occlusion, your abdominal thrusts are not going to really push anything because the air is just going to go around the object. So if they're breathing, just let them keep coughing, put them in the truck, take them to the hospital. If there's a paramedic there, they can grab the McGill forceps or whatever. But technically, as basics, we don't yet have that skill, even though it's not hard. It's just we don't want a chance pushing it back down. So they haven't, even it's a basic skill, you're not crossing any chords, but the NREMT gods have not yet given that skill to a basic. So if you've ever heard grab the McGill forceps, great, grab a paramedic and let them do it. Otherwise, just take them to the hospital, let the doctors get it. If it becomes a full occlusion, then you'll do the Heimlich. All right, we talked about interrupting CPR. The AED is the only time you're going to do that. Chest compression fraction. Should be at least 60%. What they're saying there is that you should be doing compressions over all of your CPR. You should be doing compressions at least 60% of the time. We want to try to get it to 80, 85, 90% of the time would be fantastic or whatever. But again, you do still have to stop for breathing. You have to stop for the AED check or whatever. So you really aren't going to get it 100%, at least not for long. Let me ask you this, because this is a bad habit that I see a lot of times, and this comes from people that they think that the training is worthless. And unfortunately, basic CPR training, the way that we do it for EMS as a whole, it is kind of a waste of time because we don't talk about why we're doing what we're doing. We're just reminding them 30 to 2 and stuff like that, and that's it. But why do we do 30 to 2? Let's say you've got 2 rescuers, all right, and you're doing adult CPR, 2 rescuers. So is that 30 to 2 or 15 to 2? Adult rescuer, 2, I'm sorry, adult CPR, 2 rescuers, 30 to 2. Good. Now, why are we not doing concurrent BVM and compressions? Why is it bad? Think about what we've talked about tonight. Why do we not want to do just constant compressions? Because we want constant compressions, or at least as close to it as possible. All right, you have definitely done CPR before. That is a very experienced answer. Yes, it's almost impossible to give good breaths with a BVM while compressions are going on, and that is exactly the problem. The only time that you really, in the way that the AHA teaches it, and the way everybody else teaches it, it's the only time you want to do concurrent breathing and compressions is with an advanced airway. All right, because the ET tube is going past the cords, they've inflated a balloon, and it is sealed. There is no seal. There's no mask for you to deal with making a seal or whatever. You just pop the BVM on and you can start breathing. So no matter how the patient's being moved, either on the stretcher into the truck or during compressions or whatever, you've got that seal. You can give a good breath. If somebody just throws you a BVM and says, breathe, bag this patient while I do compressions, great, but 30 to 2. All right. Just stand by it, because if you're trying to give breaths with a mask while compressions are going on, most likely the air is going to go into their stomach or just out the outside of their cheeks because you didn't get a seal because their face is moving, or you keep losing the airway because their body's moving, and all of your efforts are for naught because it's not getting into the lungs. So it's a waste of time. That is one massive, very, very common bad habit that I see. Everybody does it. And it's because they're disregarding the training. And that is because the training to them is a waste of time, and because it really is, we're not training properly. That's a problem with that's more of a problem with the educators, not the providers. All right, so when to stop CPR if the scene's not safe? Somebody, if it's an active shooter situation and the shooter comes back, maybe you should retreat. If there's a rabid dog biting your leg while you're trying to do compressions, you should probably stop and deal with the dog, that kind of thing. If the patient has obvious signs of death, so rigor mortis, which is stiffening of the body, dependent lividity, which is where their heart has stopped beating for so long, they've been dead for so long that gravity has pulled all their blood to the bottom. If the blood's hanging out at the bottom of the body, the compressions aren't going to do anything. Putrefaction or decomposition of the body means they've been dead for a while. And evidence of a non-survivable injury, so like they lost their head, literally. That would be, you're not going to do that. If there was a massive hole in their chest, you're not going to do CPR. Those are reasons when you would not start CPR. Some other reasons. All right, well, before we get to it, so this is dependent lividity. And keep in mind, too, rigors only last about 24 hours. If they've been dead longer than a day or so, they're going to lose rigor mortis. The stiffness is going to go away. That's actually that's one of the ways that they can determine the time of death is, first of all, are they stiff? All right. If not, once all that lactic acid has fell out of the muscles, then the muscles relax and they lose muscle tone. If you've ever found a, how do I say this? Because I don't want to sound like too morbid with it. Let's say you're completely unconscious, but you're still alive. All right. You could pick somebody's arm up and drop it, and it's going to have a bit of a set path that it goes as it falls out to the ground. I'm not saying that it's going to just, they're going to suddenly dodge their own face. They might, if they're unconscious, they'll probably smack themselves or whatever. But all of your muscles always have a little bit of tension in them while you're alive. When you die, you go into rigors, you get real stiff. Then all the lactic acid is finally gone completely, and you lose all muscle tone. And it is a very weird. If you've ever seen the patient moved that's been dead so long that the rigors has gone away, the limpness is not something that a living person would do. So it looks different, it feels different, it's creepy. If you see that, and you, like I said, you'll just know. It's hard to describe, but the way that they move, the way things just kind of fall out, like your fingers, if you lay your hand upright where your palm's facing up, your fingers have a curve, a natural curve to them. If it's a dead body, the fingers don't necessarily curve up like that. They're much more, gravity is just going to plop them on the ground. It looks weird. So that's something to keep in mind. If that's what you're seeing, where they have a limpness to them that just doesn't look real, doesn't look like they're alive, they've probably been dead for at least 24 hours, and they've gone past the rigor stage. What's even more creepy is when you move a dead body and the air comes out of their mouth and okay, yeah. The hell, even just guppy breaths where they're doing the agonal breathing, at that point you would do CPR. But just like if you saw that, that that means they're just getting into cardiac arrest, so they're very savable. But that's a creepy look because it looks like they're trying to bite the air, like it's solid in front of them. But if you're not sure, especially at the basic level, because it's not like you can put a 12 lead on them or any of that sort, um, unless you have obvious signs of death, do CPR. And the same goes for, like we're talking about here, your DNR order. You remember the DNR from I want to say it was chapter 3. We talked about DNRs. So they have to be valid, they have to be signed, they have to be in date, they can't be expired, and they have to be present. Don't take somebody's word for a DNR, because that may be a family member that's seeing a really big life insurance payout coming. So it has to be there, it has to be present. If they're like, oh, it's real, but we got to go get it, that's fine. Start CPR. When they show up with it, then you can stop. When in doubt, though, do CPR. All right, there is a fancy acronym for when you can stop CPR once you've started it. So like Vicky said earlier, if they start breathing again and they have a pulse, congratulations, you got them back. Yeah, sorry, my dog is, I think he's trying to convince my daughter to take him outside. T is you've transferred your patient. Well, yeah, but she's a golden retriever, so she's a really big puppy. She's like 2 years old at the moment. O is you're out of strength, and P is physician directs you to discontinue. So let's talk about out of strength. That doesn't mean you're tired. All right, that means you like can't even get up to do the compressions anymore because your core strength is just gone. So if you're laying there on the ground next to the patient, wondering if you're dying too because you've been doing compressions for 2 hours or whatever, that's when you would stop CPR. All right, you just physically could not continue. Doing CPR in the back of the ambulance between Poplarville and Hattiesburg used to make me feel like I was going to break my back because the way that you're kind of like I'm 6'3", so hunched over, you damn sure can't stand up straight in that little bitty ambulance. It was painful. It hurts to do compressions, but that's not a reason to stop because I could still physically do it. Well, that's the thing is I was the firefighter. So what am I going to do? Tell somebody else to jump in? That was, I worked a fire department and an ambulance at the time. If I was on the ambulance, I was driving the truck, so it was different. But being in the back doing compressions was because I was the firefighter. All right, we already talked about airway obstruction, so I'm not really gonna harp on that too much. Um, any questions on that? I don't want to just skip it if there's more questions about it. We talked about the Heimlich, how we would do it, when we would stop, which is either they cough it up or they go unconscious. If they go unconscious, we're giving up the Heimlich and we're going into CPR. We talked about what we would clear, right? So if it's a solid object, or if it's the tongue, you can use an OPA, NPA. You can use your manual head tilt, chin lift, or jaw thrust. If it's fluid, teeth, something like that, suction it. Do what you need to do. If it this is also something that's kind of self-correcting, but I see people do it surprisingly. When a baby is choking, an infant's choking, we're taught to keep their head down so gravity works for you, right? If it's fluid, like formula, set them up. And that's all you got to do. Usually, you set them up. Gravity, because the whole point is to let gravity work for you. Can't tell you how many times I've seen people take a baby that's choking on too much fluid, too much formula, because the first time parents overfed them, and they put them head down. And so gravity is doing exactly what gravity is going to do, and it's pulling more fluid and putting it into their airway. Um, and I get it. I definitely won't name names because that was not. I'm not trying to call anybody out. Don't let your tunnel vision stop your common sense. All right. If it's a solid object, we want gravity to pull it down toward the mouth. If it's fluid, just set them up and let gravity pull the fluid back into their stomach. Because a lot of times what will happen is first time parents they won't feed the child to the point where they should stop eating. They feed the child to the point where the child is full, and then the child gets into just like we do, right? You go eat a big meal. What do you want to do? Go to sleep? Um, so baby's tired. Parents are like, cool, okay, well, you feed the whole bottle to the baby. They want to go to sleep. That makes it easy. No more crying. They lay the baby down, and the fluid they've got so much that now that they're lying horizontal, the fluid just kind of levels off, gets into the airway, and the child starts choking. When really all they had to do at that point was set the child up, and the gravity will pull the fluid back down out of the airway. Had a patient eat real hot rice, and it swelled his airway up. Ew. Like just from burns? Or was it spicy and more like an allergic reaction? Burns. Oh wow, yeah, and that's bad. We are very limited in what we can do for that. That's a paramedic or beyond. Yeah, intubated if you could get it in. If they're already swollen, that may wind up being a surgical airway. All right, well, I'm going to go ahead and skip through these. We already talked about the obstructions. Talked about the obstructions. Like I said, 5 back slaps, 5 chest thrusts. All right, let me get to what I need to get to here. Give me a second. Okay, we're almost done. I know it's time for a break. We're actually overdue for a break, but we're getting pretty close to the end. So I'm just going to power through it. If you guys need to get up, you can, but I'm really only thinking it's going to take maybe 10 more minutes tops, and we're going to be done for the night. So some special resuscitation circumstances, opioid overdose. I know Narcan was mentioned earlier, so we're going to talk about that for a minute. Naloxone is the actual name of Narcan. Narcan is a trade name. So if another company makes naloxone, they can call it something else. We are just used to Narcan because that's the main company that makes it, and that's what they call it. But the reason that we're going to give this medication is because somebody is having an opioid problem, and that opioid overdose is causing their respiratory system to shut down. All right, that is why we're giving it. Our goal is not to wake them up. Our goal is not to fix them with that or anything like that. The goal is to stop them from stop them from their respiratory drive just going completely out, and then us having to do CPR or, at best, rescue breathing. So that being said, only give enough Narcan to restore a good respiratory drive. Don't get hellbent on waking them up. That's actually going to make your day very, very bad. There's videos, there's news articles out there of people who, because almost anybody can get Narcan, right? In fact, if you're a known drug user, in a lot of states, they will give you Narcan because you're gonna do it, right? Unless they're gonna put a cop in your house and have them just sit there and stare at you while you're doing other things. That's really awkward. But almost everybody carries Narcan. And there's been documented cases where people have given it, woke up the patient, and then the patient proceeded to beat them within an inch of their life or even kill them, that kind of thing, where the Good Samaritan got his butt kicked for being a Good Samaritan. So keep that in mind, right? We're not cops. We don't carry weapons. We're not superheroes. We're not invincible. We do too much and wake up our patient. We may be the ones that are needing the ambulance ride, because the last thing you want is some cracked out drug addict with superhuman strength because he's now suddenly got an adrenaline surge, and you ruined his high. And you didn't just ruin his high, you put him in a whole lot of pain. All right, a lot of them, that does not feel good coming out of an opioid crisis. So that's not our goal. Let's not do that. Your goal is to just kind of restore their respiratory drive. Now, that being said, what if they're in cardiac arrest? That's what the chapter is about. If they're already in cardiac arrest, do we want to give them Narcan? Does that do anything? Nope. Why not? Anybody know why? I mean, you're right. You're absolutely right. We're not going to do it. Do you know why? Yeah. The heart still needs to be beating. All right. Not necessarily restarted, but the heart still needs to be beating. It needs to go, because we give Narcan intranasally as basics. So they need to be breathing, or at least have a heart rate. If we have to bag it in, that's fine, right? You can do that. You can squirt in the nose and then start bagging them, but the blood flow needs to be there, or else it's not going to get spread out to the body. So if they're in CPR, throw the Narcan to the side, do CPR if they need it. No, I'm sorry, I just said if they're in CPR. If they're in cardiac arrest, do CPR. Once you get a pulse back and you want to hit them with some Narcan, great. But if they're actively in cardiac arrest, the Narcan is not going to do anything. It's going to, by the time you get the the blood flow going from your chest compressions, a lot of times the Narcan is just falling out of the nose. So it really didn't get into their system anyway, and it was a wasted dose. Cardiac arrest in pregnancy. Your goal is to provide high quality CPR and relieve pressure off the aorta and the vena cava. Remember, we want to always have our patients supine so that we can give good compressions. The problem with that with a pregnancy is that the lady is going to have a baby that may be 6 pounds, 7 pounds, whatever, sitting on their inferior vena cava if they're flat. And what that's going to do is that's going to crash their blood pressure. So while you're trying to do chest compressions, the weight of the child is laying on the vena cava, and those compressions can't get blood to the heart. All right, so you may have to put a board under your patient. Kind of, if you can get them on the stretcher, and I'm speaking more of a real world thing here. Put them on a board, lift the board up so that the stretcher is sitting, or so that the board is sitting on top of the little arm guard of the stretcher, so they're about 4 inches or so off of the pad. They're not supine, but they're pretty damn close. All right, and that might be enough to get the baby off the vena cava, enough for you to do compressions, and it's a good little compromise. That being said, which side do you think we want to put them on? Do we want to raise the right side or raise the left side of the patient? In other words, do we want them leaning toward the right or leaning toward the left? I was all right. So we got both. We got left or right. Anybody else want to kind of break the tie here? 2-1 on the right. So are you saying we want to lean them to the right side so that their right side is down? Is that what y'all are saying? Okay. Okay. I see where you're going with it. All right. So the correct answer technically is the left. Nicole got it. Um, it's not the heart. The heart sits more superior. The baby is not really going to do anything to the heart. No, no, no. It's okay. Don't be upset. They're very good guesses, and keeping pressure off the heart is a good answer. But remember what the reason for this is. If you're dealing with a pregnant woman and she's got a baby, the baby's lower, right? The baby's not sitting on the heart. The baby is sitting on the vena cava that's leading to the heart. And if you think about the anatomy, the vena cavas dump into the right side of the heart, which means that they're going to be on that right side of the body. If you lean your patient to the right, where the right side's down, you're only able to do it a couple of inches before you're so far over that you can't give good compressions. So if you only have a couple inches to work with, you want to go the other direction. Get the right side up so that the baby is sitting more toward the left. It's on the other side of the body from the vena cavas, and you can give your compressions and have that blood flow still getting through the vena cavas and into the heart. If you lean them the other way, the child is going to be pressing down still on the right hand side, which is the vena cava side. You would need more of a turn to get the child off of the vena cavas, and at that point, you may not be able to give good compressions. So, just something to think about. Um, you're not going to get that as a registry question. That's something I want you guys to take with you to the field. All right, and the whole reason why, like, if you think about it, we even call the recovery position the left lateral recumbent. Um, it's not for that reason, but if you want to tie it to that, it'll keep you on the right side. And even had me propped to the left during C-section. Yeah, for that reason, it keeps your baby off your vena cava. If you're either supine or a little to the right, the baby is putting pressure on that, and your vital signs, particularly your blood pressure, is going to crash, and we don't want that. But no, excellent guesses, excellent decisions. And like I said, I'm glad that you said about the heart because it shows why you chose that answer. So very good job. All right, the last thing we're going to talk about for the night is how to deal with grieving family members and loved ones, especially if it's a call that you know you're not going to save the patient, or you show up and they've been unconscious, cardiac arrest in the chair all night, and for whatever reason you're just like, oh, I'm sorry, we're not going to be able to save the patient. At that point, I must be playing with my dog up like right above my head. Um, at that point, the family kind of becomes more your patient than the cardiac arrest patient did. So it's very important that you guys have a good bedside manner because this is what they're going to remember. And if you guys, especially if you guys are going to be paramedics, if you try to act like a paragod or you are not empathetic and sympathetic with the patient, with the family and everything, that's what they're going to remember. And when they start grieving and wondering whether or not you could have really saved their loved one, uh, if that's the memory they've got of you, you're probably going to wind up getting sued. Whereas if you are sympathetic, you take their needs into account, you're still there for them, even though you didn't save the patient. When they start going through those grieving processes and that's those stages of dying, um, you know, denial, anger, all that stuff. The survivors go through that too. When they get to the anger stage, you don't want that directed at you. All right. Because if you did make a mistake, they're going to hammer you for it. So, anyway, grief support for family members and loved ones. Family members may experience a psychological crisis that turns into a medical crisis. I've seen people hyperventilate and go into an anxiety attack to the point where I actually had to provide medical care to calm them down. They hyperventilated themselves to the point where their entitled CO2 dropped and they passed out. There's a physiologic reason for that too, which we will not talk about tonight. But Family members and loved ones will remember this event in detail for the rest of their lives. They will watch your every move. And like I said, if you make a mistake, um, whether or not you get crucified for it really depends on how you take care of the family in these situations. So keep them informed. Let them know why you stopped CPR. Let them know why you didn't even start CPR. Let them know all of your decisions, because if you can justify it, they'll understand that. They may not agree with it, but they should at least understand it. Be concise, be clear. Don't be subjective, be objective. I know that sometimes it's hard to do, and be tactful, but just be like, look, I'm sorry. Um, Show them, be like, hey, do you this, and educate. Be like, look, this line here of blood, this is called dependent lividity. This happens after somebody has been passed away for X amount of time. Once we see this is a sign of death, and we know that we aren't going to be able to get them back. That's their blood having pooled at the bottom. Blah 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 blah. All right, that kind of stuff will go a long way with the family. And just be really considerate. So take the family somewhere quiet, away from the patient. You can be in another room. It can be outside, like if it's a car or something like that. Kind of pull them away so that they're not staring at their loved one. Stay calm, be reassuring, but don't give them false hope. Don't lie to them. That kind of thing. You can use the patient's name. Just be respectful with it. Like, for example, my name's Robert. All right. Everybody that knows me knows that I always say my name doesn't start with a B. So don't call me Bob. Don't call me Bobby or any of that crap. My friends all call me Rob. So if y'all were to use somebody's name, just be careful what you use. All right. You can use their real name. If you knew the patient, a lot of you guys working in small communities, you're probably going to know the people that you're responding to. So use that. All right. Use that I'm not going to say use it to your advantage. Use it to the advantage of calming the family down. That'll go a long way. Use eye contact, and it says appropriate touch. Um, be careful with that. That's all I'm going to say. All right. Expect emotion. Usually it's going to be pretty pronounced from some people. Some people aren't. Some people may not, don't let it be a red flag that there might be foul play, right? Some people just don't show emotion. Some people don't cry. They don't really react. They react in their own way, and they may react later on. The shock of it may be stopping them from having a real big emotional response. Whereas some people will cry a river right there in front of you. It just depends on the person. Be supportive, but don't hover. But at the same time, don't just leave them alone either, right? Ask if a family member or a friend can be called, especially if it's just one person. Let's say it's an elderly couple, husband and wife. They've been married for 50 years. They're 70 years old, and the husband died, and it's just the woman or just the wife, and that's it. That's the only person there. Try not to leave them alone if you can help it. And also take some time and talk to the kids. Even if it's just to say, hey, my name's Rob. I was the EMT. I'm sorry that I wasn't able to save your grandfather or whatever. I just want to make sure you're okay and see if you have any questions. Is there anything that I can answer for you? Kids are smarter than we give them credit for. They notice a lot more than we give them credit for. And if we ignore them, they'll remember that just like the adults will. So that kind of becomes your priority when you've had to call a patient on the scene or something of that sort. But that's it. Just be. We call it, if you look at your assessment sheets, and I'll say this, and I want to move on from it. We call it patient affect. All right, you have to be human. You have to treat your patients like they're human and not beneath you or something like that. And that's easy not to do in these situations, but the same rules kind of apply. You still don't want to be like, well, this person's dead. Call the coroner. We have terms that we use to cope with things like DRT, dead right there. Whatever. We'll joke about things and the things that we do to kind of in reality, our humor is pretty dark. All right. And when you're in EMS and fire and all that stuff. So try not to do that in front of your patient's family. That's a good way to wind up in the courtroom. All right, education and training for the EMT. Your CPR skills can deteriorate over time. I guarantee you don't do it as often as you think you do. I hear it a lot from coworkers, from people that I've taught, where they're like, I don't really need this course. Can you just give me the card because I do CPR all the time? No, you don't. All right, if you stop and think about it, you really don't. Yeah, that's kind of our bread and butter, but we don't do it all the time. If you do it once a month, you do it a lot. Most people only do it once or twice a year. Some people don't even do it that often. That's why we do a CPR refresher every 2 years. I will say this, I know that CPR refreshers can suck. Even it's just 3 hours of death by DVD. And then you beat on a mannequin for a couple minutes and then you're out of there. And it kind of becomes like 3 hours of torture that we just have to get through, and that's all. If that's the kind of CPR training you're getting, say something. All right. I'm not gonna try to tell you guys that our CPR training is the best in the world, but I try to make it good. I try to teach more than just the numbers and stuff like that, and tell you why we're doing things the way we do. And if we get a change, if a new curriculum comes out and they've made a change, well, why did they make that change? That kind of stuff is important because it really drives home the importance of why you're doing what you're doing. So just keep that in mind. Don't let your outlook on training get to the jaded point where you just don't take it seriously. And as far as educating the public, be an advocate for that, right? Because if you're the ambulance provider and you're 20 minutes out from somebody that's in cardiac arrest, it would sure be nice if the people that are there that called 911 knew how to do CPR before you arrived. So do that. Offer CPR classes. A lot of fire departments will do CPR classes for just the cost of a card, at least for their guys, especially those that are in small communities. Because the more people that know CPR, like say the Walmart employee, or in the last time I worked a CPR code, was an elderly patient that fell out on aisle 7 of the local grocery store. And thankfully, the person stocking the shelves on that aisle saw it happen and knew CPR. The length of time it took us to get there because of traffic, if that hadn't happened, there was no saving that guy. But as far as I know, he's still alive. And it was the community response, the fact that stock boy knew what he was doing, that kept the guy alive. It wasn't us. We took over, but we didn't save him. It was that store employee. So if you can teach people, great. If you guys want to learn how to be CPR instructors, we do that as well. You don't have to go through us, but we are an avenue for you if you want to become a CPR instructor. But that's it for the night. There was that other slide, but we were just talking about it. So that's it. I'm not going to torture you guys any longer. I know we've been at it for an hour and a half since the last break. Is there any questions about CPR specifically, or anything that we've covered tonight? Not necessarily shock. We'll go over that. Yeah, no, don't ever say anything will be okay when it's not. 10 seconds. Is that a question or a statement? All right. If there's nothing else, I'm going to go ahead and give you guys your code for the night. It's going to be, let's see, what chapter is this? It's chapter 13, right? All right. So your code will be BC Bravo Charlie 13, and we will go with F for February. Congratulations. So BC13F, that will be your code for the night. It's in the chat for you guys that can see it. Everybody that catches the recording, I know you can't. So BC13F. And if there's no other questions, we'll call it a night. You guys should have Chris back on Tuesday. I think it's Tuesday. Today's Thursday, right? By Tuesday, his stuff should be fixed, and you'll be back to your normal instructor. If not, you get to listen to me again. But otherwise, you guys have a good night. Keep up the great work. And if you need anything, let me know.